All right, so we'll go ahead and get started. Welcome everyone back to UCSF's Cardiology Grand Rounds. I'm honored to present today Dr. William Fearon. Dr. Fearon is Director of Interventional Cardiology at Stanford University School of Medicine and Chief of the Cardiology Section at the VA Palo Alto Healthcare System. Over the course of his career as a clinical investigator, Dr. Fearon has focused on studying coronary physiology. He has been the principal investigator of numerous multi-center clinical trials, including the FAME trials, looking at the use of fractional flow reserve, or FFR, in guiding percutaneous coronary intervention. He has long been funded by the NIH and is currently the principal investigator on an NIH grant evaluating cardiac allograft vasculopathy. He has over 250 publications and serves on the editorial board of multiple cardiology journals, including JACC and Circulation. And in addition to all of this, he has also won multiple teaching awards from the House staff at Stanford University. With that, Dr. Fearon, welcome. I'm very excited to hear your talk, and I will hand it over to you.
Great. Thank you, Layla, for that nice introduction. I'm noticing that I can't share my screen. I don't know if, are you able to?
Okay. That's an issue on my end. 1 second. Okay, try again.
Okay, great. All right. Is that showing up okay for everyone?
Yeah, that looks perfect.
Okay, great. Well, yeah, thanks again for the invitation. It's really a true honor to be able to present at UCSF. I'm just sorry we can't do it in person. These are my disclosures for this talk. And what I thought I would do is review historical data comparing PCI with CABG for multivessel coronary disease, then talk a little bit about what has changed since those historical trials were done, namely the evolution of stent technology and the addition of coronary physiology to PCI, and then focus in on the FAME-3 trial, which we just recently completed. So I thought I'd start with a case presentation. This is a 53-year-old man with hypertension, dyslipidemia, tobacco use, and he was admitted with chest pain. He was at work as a technician. He developed some left-sided chest pain walking down the hallway, described as a burning. It lasted about 5 minutes. It resolved with rest. However, he and his coworkers were concerned enough that EMS was called, and he was brought to the Stanford Emergency Department. He was found to be hypertensive, but otherwise he had a normal cardiovascular exam. This was before we had high sensitivity troponin, and his troponin was just slightly elevated. His hemoglobin A1C was okay, and his LDL was a bit elevated at 142. This was his presenting ECG. You see that there's some sort of lateral ST segment depression, maybe some poor R wave progression, but not a clear STEMI. So at this point, the question comes up, this is a patient with an ACS, a non-STEMI, should we admit, treat medically and do non-invasive imaging, or should we move more directly to invasive coronary angiography? And the recent guidelines for coronary revascularization suggest that in a patient like this, an invasive strategy with the intent to proceed with revascularization is indicated to reduce cardiovascular events. Now, I would mention that our evaluation of patients with chest pain has certainly changed. These are results from the ischemia trial, which was led by my colleague David Marin, which I think we're all familiar with, patients who had stable coronary disease. So not a patient like the one I'm presenting, but stable coronary disease where they were randomized to an upfront invasive strategy if they had significant ischemia and a CT scan showing no left main disease, versus a more conservative strategy where medical therapy was focused on first. And you see that there was no significant difference in the primary endpoint out to 3 to 5 years. So in those patients, we have more time and we'll often focus on medications first. But in this guy with ACS, we brought him to the cath lab, and this is a left coronary angiogram. You see the LAD coming down, and you see there's a fairly significant looking proximal LAD lesion. If we look at the circumflex, there's also disease both in the proximal circumflex and then in that obtuse marginal branch. And then finally, the right coronary is very tortuous and angulated and has multiple spots of potential concern throughout its course. So the question now is, this patient has multivessel coronary disease in the setting of an acute coronary syndrome. Revascularization is indicated. Should we perform PCI or CABG? And we'll get back to that at the end of the talk. But what I'd like to do now is review some of the historic data. This is a meta-analysis that my colleague Mark Glatke performed more than 10 years ago now, that looked at 10 randomized studies that had been done up to that date, comparing CABG with PCI, over 7,000 patients. And they found no real difference in death or MI between the two groups. However, when they looked at subgroups, patients with diabetes, clearly there was an interaction, and diabetics seemed to fare better with bypass compared to PCI, whereas non-diabetics, there was really similar survival during long-term follow-up from those studies. Now, this, of course, it's randomized studies at select centers and probably select patient population. It's always good to look at a more real-world type population, and that was done in the ASSERT registry, which was a registry of Medicare-aged over 65-year-olds who were treated with either PCI or CABG, almost 200,000 patients. And the investigators did propensity matching to try to account for the lack of randomization. And you see that there was a survival benefit in this study with CABG, with the caveat that, again, this wasn't randomized, but at least it might have been more real world, and certainly it was a very large number of patients. Now, those two reports were mainly with either just PTCA angioplasty alone or bare metal stents. And it wasn't till the Syntax trial was performed that we had data with drug-eluting stents. And this study was 1,800 patients with either three-vessel disease or left main disease. And they were randomized to stenting with the Taxus, one of the first generation drug-eluting stents, or to bypass surgery. About a third were diabetic. They used almost 5 stents per patient with an average of 86 millimeters. So a pretty aggressive stenting strategy in this trial. And what they found at 1 year, their primary endpoint was death, MI, stroke, or repeat revascularization. And the study was set up as a non-inferiority trial, and they didn't meet that. In fact, bypass surgery was superior to PCI, as you can see from this Kaplan-Meier curve. Now, most of that was driven by repeat revascularization, as is shown here. The investigators did follow patients out to 5 years, and you see that there's a strong signal to reduced mortality at 5 years with a p of 0.1 with bypass compared with PCI. Myocardial infarction certainly looks like it was reduced with CABG. And stroke seemed to be slightly higher with CABG compared to PCI. And of course, MACE remained lower, so death, MI, stroke, or repeat revascularization with CABG out to 5 years. Now, one of the tools that emerged from the Syntax trial is the Syntax score. This is an angiographic scoring system based on various criteria shown here, which helps gauge the complexity of PCI. And it really applies mostly to PCI. It doesn't really apply to CABG. It just has an effect on how people do after PCI. And that was shown in the Syntax trial. The lowest tertile Syntax score, which was less than or equal to 22, you see that there was very little difference between PCI and CABG with respect to the primary endpoint at 1 year. But then as you get into the intermediate tertile, and then certainly the highest tertile, CABG results stay about the same, but PCI gets worse. So this highlighted the concept that with less complex disease, you can get a reasonable result with PCI, but as you get more complex, CABG seems to be beneficial. So what have we learned so far? We've learned that patients with more complex disease and diabetics fare better with CABG when compared to angiography-guided PCI. So I should mention that Syntax and the other studies were all guided by angiography. They didn't have physiology as a component in how PCI was performed. And they were using, at least Syntax was using, the first generation drug-eluting stent. And so how do we explain this? The classic explanation is that, when we do PCI, we fix the culprit lesion, but we don't address any of the potential future non-culprit lesions. Whereas when you do bypass, you not only bypass the culprit lesion, but also a fair amount of the rest of the vessel and potential future culprit lesions. So that would certainly explain a reduction in MI and could potentially explain the long-term trend towards lower mortality with bypass. But things have changed since at least Syntax was done. Stent technology has evolved, and fractional flow reserve guided PCI has been shown to improve outcomes with the traditional angio-guided PCI. And so when we talk about the evolution of stents, just to remind those who aren't familiar, the first generation drug-eluting stents were the Cypher or Taxus. They had sirolimus or paclitaxel coating, and they were thicker struts made out of stainless steel and had a thicker polymer coating that attached the drug to the strut. And this was a durable, and it turned out, inflammatory polymer. And so it seems like the polymer, led to inflammation and almost like an allergic reaction of the vessel, such that the risk of stent thrombosis, particularly late after, continued to be there. And we had to keep patients on long-term dual antiplatelet. And this was a major issue. Now, fortunately, the technology's improved, and the current generation drug-eluting stents, you may be familiar with some of these names: Xience, Resolute, Synergy. They have everolimus or zodorolimus coating. They have thinner struts, and the metal is cobalt or platinum chromium, which has the same radial strength as the stainless steel, but is thinner, which is beneficial. And there's a thinner polymer coating, and it's more biocompatible. And so with these stents, studies have shown, particularly in high bleeding risk patients, we can do even just 1 month of dual antiplatelet therapy, and then you can safely stop one of the antiplatelet agents. Direct comparisons of these newer stents with the first generation have shown significantly lower rates of myocardial infarction. This was a study comparing the everolimus eluting stent to the first generation paclitaxel eluting stent, and you see lower rates of MI both in the short term and longer term, out to 3 years. And this was likely partially due to the fact that there were lower rates of stent thrombosis, both early and late within the first year, and very late, more than 1 year out, again, because of some of the issues in the technology that I described. And the combination of less MI, less stent thrombosis likely resulted in the lower mortality seen out to 3 years when you follow these patients with the benefit in the current generation DES. So basically, these studies showed that we can have lower rates of death and MI compared to the stent that was used in the Taxus trial. Now, the Syntax trial. Now, what else has changed? Well, we now use coronary physiology to guide our PCI. And as a reminder, this is a technique that we typically use in the cath lab with a pressure wire, where we can measure the distal pressure with the wire, the sensor, and then we compare that to the proximal pressure or aortic pressure measured with the guiding catheter. And we typically do this when we measure FFR during maximal hyperemia. And so we give adenosine. In this case, intracoronary adenosine was given, and flow increases. And in that way, we're kind of simulating a stress test on the cath lab table. And we look at the mean pressure distally during maximal flow compared to the mean pressure proximally. In this case, it was 60 over 100, or 0.60, meaning the FFR, or meaning that 60% of the blood that should be getting to that part of the heart is actually getting there. And we've learned that FFR value, anything below 0.80, generally correlates with ischemia on non-invasive testing. It also predicts adverse outcomes with medical therapy. Whereas if the value is above 0.80, medical therapy tends to do just as well, if not better, than stenting. So the first study that really validated this approach was the FAME-1 trial. This was just over 1,000 patients who had multivessel disease. And that was amenable to PCI, and they were randomized to either the traditional strategy at that time, angiography guided, where basically you took the clinical information on the patient and you did the angiogram and decided based on those findings where to stent, or an FFR guided strategy where FFR was first measured across each vessel that had a disease, and then only if the FFR was abnormal did you get a stent. And what we found was that at 1 year, the major adverse event rate, death, MI, repeat revascularization, was significantly lower in the FFR-guided patients, despite the fact that they got significantly fewer stents. And this was due to a relative risk reduction that was similar across each of the components of the primary endpoint, and death and MI alone was also significantly reduced. Now, that study kind of raised this concept of anatomic versus functional coronary disease, meaning in those patients with angiographic three-vessel disease or anatomic three-vessel disease, it turned out once you measured FFR, the vast majority only had single or two-vessel functional disease, and that some of the lesions were not significant based on FFR. And the reason this is relevant is because it allows us to calculate what we call the functional syntax score. And so in the FAME-1 trial, we took all the patients who had FFR measured, and we calculated the anatomic syntax score in the usual fashion and divided them up into tertiles, as shown here. That was without FFR. Then we took into account FFR. So any vessel that had a negative FFR, we subtracted those lesions out from the syntax score to calculate a functional syntax score. And not surprisingly, that shifted about a third of patients from a higher tertile to a lower one. But what I think is even more relevant is that the functional syntax score turned out to be a better discriminator for the risk for death or MI following PCI. And the number of patients, or the percentage of patients in the highest risk tertile, was lower. It went from 32 to 20%, and we were able to shift more than half of the patients to the lowest tertile. And so one can envision that by doing this, you can identify which patients would benefit more from PCI versus bypass surgery. So another concern that comes up from FAME-1 trial is, well, what about those 70% narrowings that had a negative FFR? Are they going to come back to haunt you, or is it safe to treat those medically? And one way of looking at that is by looking at what we call the residual syntax score. And this is basically after you've done PCI and those lesions that you leave behind, you calculated the syntax score again, and it's the residual syntax score. And one could imagine that if those lesions were going to cause a problem, the higher the residual syntax score, the higher your event rate would be during follow-up. But what we found was that there was really no difference in outcomes based on the residual syntax score after FAME-1, meaning that after FFR-guided PCI, the degree of residual disease doesn't predict events when it's not functionally significant, i.e. not causing ischemia. And so that was reassuring as well. Now, one of the criticisms of FAME-1 was that there was no medical therapy arm. Now, 30% of the patients were ACS, but certainly in the other patients who were stable, you could argue based on Courage and other trials that had been done at that time that we should have had a medical therapy arm. And so that's what prompted the FAME-2 trial. And this was a study of just stable coronary disease patients, single or multi-vessel, who were being considered for PCI. And the key difference between this study and Courage, which was sort of the reference study at the time, was that FFR was measured first before the patient was randomized. And the reason that was important was that a quarter of patients, even though the operator thought they needed a stent, had a negative FFR. And so they weren't included in the study because we know medical therapy does just as well in that case. And including them would only potentially dilute any benefit from PCI. So in order to be in the study, you had to have at least one lesion with an abnormal FFR, and this enriched the population with truly ischemic disease. And then those patients were randomized to medical therapy alone or PCI plus medical therapy. And the primary endpoint was death, MI, or urgent revascularization at 2 years. And this shows the outcomes. The red line represents the patients who had an abnormal FFR who were randomized to medical therapy. The blue line represents patients with an abnormal FFR who had PCI, and then the green line are the registry group, the patients with a negative FFR who were managed medically. And you see that once the patients who had ischemia had PCI, their event rate mimicked the non-ischemic group. And you see that the patients with medical therapy had a much higher event rate. Now, most of this was driven by urgent revascularization, hospitalization requiring urgent revascularization. And there was some numerical difference in MI, but one of the criticisms was, well, this was unblinded. The patients or the physicians could have been biased and brought these patients back because they knew they had a lesion. And so one way of looking at that is we looked at just the medical therapy patients. So those in the registry and those who were randomized with a positive FFR. And we looked at the 2-year outcomes with medical therapy alone and broke it down based on their FFR value. And you see that there's a real gradation. It's not, if it was just purely bias, you would expect everyone with a negative FFR to do well and everyone with a positive FFR to come back. But you see that it looks like there's a biologic phenomenon. The worse the ischemia, the higher the chance of coming back. And I think in a multi-center randomized trial, you can argue that it would be really impossible to try to plan this kind of result, just based on bias. Another argument is that when we followed these patients out to 5 years, the relatively hard endpoint of spontaneous MI was higher in the medical therapy arm. And this, in fact, is what was seen in the ischemia trial too, that spontaneous MI in patients with significant ischemia was higher when they were treated medically compared to revascularization. So I think this also argues against bias or unblinding. The final piece that I think argues against that is shown here. In this study, we included FAME1 patients too, stable ones. So again, it was all stable patients. And there were patients who had negative FFR who were treated medically. And then there are patients who had PCI. And what we're looking at is their change in their EQ5D, their quality of life from baseline to 1 month. And what you see is that the medical therapy patients, they didn't really change much. Presumably they had non-ischemic disease and their symptoms weren't from angina. And so the medical therapy didn't really have an effect. Now, in the PCI arm, we break it down based on how low their FFR was. And again, if there was just a placebo effect, you would expect anyone who got PCI to have a similar improvement in quality of life. But what you see is that there's a graded phenomenon. The worse their FFR, the greater the benefit of PCI with respect to their quality of life. And I would argue that patients weren't aware that they had an FFR of 0.6 versus 0.78 and probably couldn't understand that if they had 0.6, that meant worse and that they're going to have more of a benefit. So I think this really argues again against a purely placebo effect. And this kind of argues against the Orbita trial, which you remember was the sham control trial that suggested PCI really only has a placebo effect. This does argue that there's a biologic effect. And maybe you're not convinced by that, but if you look at this slide, this is now the delta FFR. So this is measuring FFR before PCI and then after PCI and looking at how great an improvement you had. So the greater the improvement in your delta FFR, that would mean the greater the relief of ischemia. And we're looking here at the change in quality of life from baseline to 1 year. And again, you see the patients with the biggest delta FFR, the greatest relief of ischemia, had the greatest improvement in quality of life, whereas those with just a smaller amount had much less improvement. And again, I don't think the patients knew what their delta FFR was. So what I'm trying to highlight is that I think there is a biologic effect, a benefit as far as symptom relief with PCI. Now, how does this happen? How does this work? Why is physiology predictive of events and why is a negative FFR safe to treat medically? Well, it's still not clear, but these are some compelling data that looked at the relationship between FFR and the production of TNF alpha, an inflammatory marker. And those patients with low FFR had significantly greater production compared to those with high FFR. And after PCI was performed, the production also went down, suggesting that maybe somehow there's an crosstalk between ischemia or a pressure gradient and plaque vulnerability and inflammation. To further support that argument was this study from Korea, where they looked at almost 300 patients who had coronary CTA, and they all had to have at least one 30% or greater lesion on CTA. And then they all underwent invasive FFR measurement. And they correlated the FFR value with the number of high-risk plaque characteristics on their CTA. Things like, positive remodeling or spotty calcification or napkin ring sign. And this column on the right here is showing those patients with high FFR above 0.90. And you see that the majority of patients had no high-risk plaque characteristics, and only 3.5% had more than 3. And then as you go down to lower values of FFR, and you go to FFR of less than 0.60, now you see the reverse. The majority of patients have 3 or more high-risk plaque characteristics, and it's only 3.4% that have no high-risk plaque characteristics. So again, it argues that when we're measuring physiology, we are detecting something going on with the plaque, and you could argue that this may be even a more beneficial way or accurate way of looking for plaque vulnerability, as opposed to doing, IVUS or OCT or whatever. So what have we learned about FFR? So it identifies lesions which are not hemodynamically significant and will respond well to medical therapy alone. This avoids the acute and long-term risks of unnecessary PCI. It also identifies lesions which are hemodynamically significant, where the risk of the lesion is higher and where the benefit of PCI likely outweighs the risks. So that prompted the FAME-3 trial. The objective of this was to demonstrate that FFR-guided PCI with a current generation drug-eluting stent would be non-inferior to bypass surgery in patients with multivessel disease. This was a study that we ran, sponsored by Stanford. We had research grants from Medtronic and Abbott, but they were not at all involved in the design or interpretation of the study. And there was an independent clinical events committee and data safety monitoring board and statistical committee, all shown here. The way the study worked is that we looked at all comers with 3 vessel disease, not involving the left main, that was amenable to either PCI or CABG, and patients were then randomized in a 1-to-1 fashion to either CABG or FFR-guided PCI with a current generation DES. The primary endpoint was MACE at 1 year, including all-cause death, MI, stroke, or repeat revascularization. It was set up as a non-inferiority trial with a margin set at a hazard ratio of 1.65. When we look at the baseline characteristics of patients, unfortunately, it wasn't as diverse as we had hoped. It was mostly white, middle-aged men with typical risk factors. About a third were diabetic, 40% were presenting with ACS. When we look at some procedural characteristics, not surprisingly, the time to the procedure duration, and the length of stay in the hospital were all significantly shorter with PCI. But the number of lesions was similar, just over 4 lesions. About 20% had a CTO, almost 2/3 had bifurcation lesions, and the syntax score was around 26 in both groups. So fairly complex group of patients. We had actually hoped that it would be less complex than it was. Now, when we look at the primary endpoint, what we see was that it occurred in 10.6% of the PCI arm and 6.9% of the bypass arm. This had a hazard ratio of 1.5. And the upper bound of the 95% confidence interval was 2.2, so that was above 1.65. So PCI did not meet the criterion set for non-inferiority compared to bypass. Now, when we look at some of the secondary endpoints, there was actually no real difference between any component of the composite, although there were some numerical differences. But death, MI, and stroke wasn't statistically different, but again, there was numerical difference at 1 year. When we look at some safety endpoints, there were lower rates of severe bleeding, acute kidney injury, significant arrhythmia with PCI compared to bypass. And there was also a lower rate of rehospitalization within 30 days compared to bypass. On subgroup analyses, There was no significant interaction with most of the subgroups, the only caveat being the syntax score. So patients with the low syntax score seem to have more favorable outcomes with PCI. When we look at that here broken down, you see that numerically there was a lower rate of the composite in the low syntax score, but then when you get to the intermediate and the high syntax score, the reverse is true. Bypass outperforms PCI. So it's always useful to compare, and this was one of the goals of the study, to provide some contemporary data, compare to a historical sort of reference, and the syntax trial is just that reference. And fortunately, it was a very similar patient population. These are the baseline characteristics of the two studies, and you see that there's pretty good matching with also similar number of lesions identified and similar syntax scores. And when we look at the endpoint of MACE, which was also very similar between the two trials, the only difference was in the definition of MI. It was slightly different, with it being more stringent with syntax than it was with FAME3. You see that basically the event rates are higher than what we saw in FAME3, and even CABG is higher than PCI. Now, when we designed FAME3, we expected a CABG rate similar to what we had seen in syntax. But as you can see, the CABG arm performed better in FAME3. So the good news is that both groups are doing better. The other thing you'll notice is that the difference between PCI and CABG has narrowed compared to the historical study. Now, another thing to look at, and this is maybe a good message for the fellows, don't always just read the abstract and the conclusion of the abstract. It's good to get into the weeds a little bit. And one of those areas in FAME3 is how was MI defined? Because although it's considered a hard endpoint, it actually may not be that hard. And so in FAME3, we defined procedural MI in the same way for PCI and CABG. We did it that way, first of all, because we think it should be that way, but also because that way the clinical events committee could remain blinded and they wouldn't know what treatment the patient had, and they could just adjudicate whether or not it was an MI. And to have an MI, you had to have an elevated biomarker and at least one of the following, either new Q waves, a coronary occlusion, or loss of viable myocardium. So it was a fairly strict definition. Now, there is another definition that has been tested and validated and shown to be prognostically important after PCI. It's called the SCAI, or Society of Cardiac Angiography and Interventions definition. And it has two components. One is just a biomarker elevation, and the other is a slightly lower biomarker elevation, but new Q waves. And so by having just a biomarker elevation, it's a little less stringent or more liberal a definition. And it's interesting when you look at in FAME3, the definition that we used, which I think was the appropriate definition, has similar event rates. But interestingly, if we had applied the SCAI definition, first of all, the procedural MI rate is much higher, but also it's 4 percentage points higher with CABG. And so you can envision that if we had used this, it would have totally changed the interpretation of the trial. And in fact, the Excel trial looking at left main used a similar definition to SCAI. So it just gives you an idea of why they had the results they had and we had the results we had. Now, one thing that I think is important to remember is, of course, the patient and how the patient feels, because a lot of patients will trade, feeling better for having an event, like an MI. And so quality of life, we looked at that at 1 year, and we found that there was no difference in quality of life at 1 year between the two groups. However, not surprisingly, the trajectory of improvement was significantly better with the PCI group, because at 1 month, they had significantly higher quality of life scores, not surprisingly. So that was reassuring for PCI. The other thing that was reassuring is that when you look at significant angina, CCS grade 2 or higher, both groups had significant angina at baseline. And then when you got out to 1 year, there were similar rates of significant angina between the PCI and CABG arms, which was also reassuring, and they're both low. And finally, when we look at returning to work, so we looked at younger patients, those who are less than 65, the ones more likely to be working. And what you can see here is that basically all of the PCI patients returned to work, whereas significantly fewer patients after bypass return to work by the time you get to 1 year. So I think all of these factors are important, patient outcomes that we need to also pay attention to. Now, one thing that we were interested in looking at is whether, we showed that in the low syntax score, the less complex patients, we could identify a group that can do reasonably well with PCI. But in this higher syntax score, above 22, either intermediate or high risk, certainly some of these 13% event rate patients, some of them probably did fine and had no events, and some did really bad. Obviously, it's a dichotomous thing. So we wondered if we could pull out some of those patients, because 2/3 of the patients fell into this category. But if we could calculate the functional syntax score, take into account FFR, and identify some lower risk patients who had good outcomes after PCI, then maybe we could improve our findings. And so if you look at, again, the anatomic syntax score, you see that 2/3 had an intermediate or high risk, and 1/3 had the low syntax. But then when we calculate the functional syntax score, we can shift half the patients become a low functional syntax score. And when we look at the event rate in those low functional syntax score, it's very similar to bypass. So basically, by calculating the functional syntax score, we can identify half the patients who will have a good outcome. On the other hand, we can also identify half the patients where you might want to think about bypass as opposed to PCI, because they have a much higher event rate with PCI. So I'll finish up by going back to our patient. This was the 53-year-old man with the acute coronary syndrome and 3-vessel disease angiographically. So he was actually enrolled in the FAME-3 trial, and he was randomized to FFR guidance. And so this was the FFR of his LAD. The green line represents the distal pressure, and the red line, the proximal pressure. And you can see, not surprisingly, it was a very abnormal FFR, 0.57. So we went ahead and did PCI of his LAD. Then we measured FFR of his circumflex, and here too, you see it was a very abnormal FFR, 0.54. And so he went and had 2 stents, one in the OM and one in the circumflex. And then finally, we got to the right coronary, and we were thankful that tortuous angulated right was not functionally significant. So we didn't have to put in multiple stents, because we know that with medical therapy, he'll likely have just as good an outcome. And if you look at his syntax scores, around 28, and by removing all of those lesions in the right coronary, it goes down to 15, which would suggest that he should have a good outcome. And now he's a patient I've been following in clinic, and he came back recently for his 4-year follow-up. And he's had no intervening cardiac events. He feels well. He's able to walk about 3 miles without symptoms. He's currently on aspirin, a high-dose statin, ACE inhibitor, and beta blocker. His blood pressure is reasonably well controlled, and his LDL is 57. So he's had a very nice outcome with his treatment. So in conclusion, in patients with 3-vessel coronary disease, FFR-guided PCI with a current generation DES did not meet the criterion set for non-inferiority in comparison with CABG in terms of death, MI, stroke, or repeat revascularization. 1-year rates of death, MI, or stroke were not significantly different between the 2 groups. MACE rates for both groups were lower than with CABG in the syntax trial. The quality of life and significant angina were similar at 1 year between the 2 strategies. FFR-guided PCI performed favorably in comparison with bypass in half of the patients who had less complex disease based on the functional syntax score. And in patients with more complex 3-vessel disease, CABG remains the treatment of choice. So what's next? Well, in Paris at the EuroPCR this May, we'll present the 3-year outcomes, and we're just going to focus on death, MI, and stroke. As you saw, repeat revascularization was the main difference between the 2. And so it'll be interesting to see, and we'll look forward to sharing those results in May for death, MI, and stroke between the 2 strategies. And then we will be following patients out to 5 years as well. And obviously that will be critical data too. So with that, I'll stop, and thank you for your attention.
Thanks so much, Dr. Fearon. That was such a great talk covering the FAME trials and the use of FFR in revascularization. So if anyone in the audience has a question, please raise your hand or type it in the chat box that you'd like to ask a question, and we can get through them. Dr. Almaria has a question, it looks like.
Yes, thank you. Bill, that was an absolutely fantastic talk and really just such a nice overview of how the field has evolved over time to prioritize the importance of functional data, and certainly in demonstrating the, the superiority of revascularizing patients with functionally significant lesions. And you, of course, have been the driving force behind this. So again, thank you for presenting all of this. I'm curious, one piece that I don't think has been robustly addressed in the literature, I'm just eager to get your thoughts on it, is whether FFR or IFR is valid in guiding CABG. So meaning if you have a patient that is already going to CABG, there's really no data that suggests whether a surgeon should guide their decisions regarding what lesions to graft based on FFR. The surgeons, I think historically, many of them will bypass anything that's over about a 50% angiographic significance. But as we all know, once a vessel is grafted, there certainly is an acceleration of the atherosclerotic process. And so whether them being more conservative with the grafts that are placed based on functional data would be clinically beneficial, I don't believe has been addressed, but would welcome your thoughts.
Great. Yeah. Thanks for that question, Sammy, and welcome out to the West Coast and congratulations on your new position. It's great to see you and have you out here.
Thank you so much.
Yeah. And yeah, that's an excellent question. And in fact, some people have criticized FAME3 because we didn't measure FFR in all the CABG patients. And the reason we did that were twofold. I mean, one was logistical, because some patients get referred to centers after having an angiogram done outside for CABG, and we wanted to include them in FAME3, but if they got randomized to CABG, then it would mean a trip back to the cath lab to have FFR measured. And so that was logistically a challenge. The other reason, I guess there's three reasons. Another reason was just what you're alluding to. There aren't really great data to support FFR-guided CABG yet. And then the final reason was more of a trial design. In a way, it would sort of shoot ourselves in the foot, because there would be patients who were being considered and who would be quote unquote appropriate for CABG, and then FFR would be measured, and it turned out they only have 2 vessel or 1 vessel disease, and they wouldn't be included in the study. And so we'd end up including only patients with severe 3 vessel disease that have all functionally significant lesions. So it would negate any benefit of FFR. So those were the rationale. Now, as far as data, I mean, there have been some small randomized studies where they've been randomized to FFR guided versus angio guided CABG. And like you alluded to, there wasn't really much benefit. And I think that's because from a surgical perspective, at least acutely, there's not a huge downside in the OR from putting in a third graft. It adds a little bit of time, but it's not really a big deal. Now, like you mentioned, it could have big impacts on progression of disease. And so these studies, they haven't so far shown, they don't have real long-term follow-up, but at least short-term follow-up, they haven't shown a benefit, at least with clinical outcomes. They do show that you will use fewer grafts, and you have a quicker procedure. And so in that regard, there may be a role for FFR, but we don't have good data showing that it really improves outcomes. But again, these are limited data and not with long-term follow-up.
Great question. Dr. Kaiser, you would raise your hand?
Yes, Bill, congratulations on this terrific body of work. I had a question about the definition of MI, the comparison of the FAME3 and the SKY definitions. So not being an expert at this, take that with a grain of salt, but I was wondering whether the SKY definition with lower elevations of the biomarker of the CKMB actually also predicts adverse outcomes. And so why discount it? Why use the more, the more pronounced definition?
So meaning just use the lower one in addition to Q waves, as opposed to just using the biomarker alone, or?
Yes.
Yeah. I mean, I think, to be honest, in looking at it, I think this comes from data that other studies have shown, where these large biomarker elevations without any other component are actually prognostically important. now, particularly after PCI, but also to some extent after bypass. And they often just get ignored, because these biomarkers typically aren't measured after bypass. And so I think the rationale is to have a more inclusive definition where you're picking up all of these events. But again, there's been criticism, of course, to that as well. And so I think, there's pros and cons. And that was part of the reason we didn't want to get into this whole, controversy that occurred with the Excel trial. And I mean, we had designed FAME3 even before that controversy had happened, but we thought we should stick with a more accepted definition. So basically, we took the universal definition essentially, but it was the one just for CABG, and we applied that to PCI too, because we felt that we wanted to have the same definition in both groups.
Dr. Marcus, you had a question?
Yeah, thanks, Bill. Awesome talk. Glad we could get you up here. So I have kind of a mechanistic question that probably will require some speculation on your point, on your part. I still don't understand, and maybe I'm missing something, why bypass is apparently so much more effective, especially when it comes to MI, given the fact that the likelihood of the MI is not where the culprit lesion is, as you alluded to, versus PCI, all else being equal, especially in these complex patients where you'd think all the advantages are stacked against CABG, given how severe and violent it is. It's still, the bypass is still touching down at one discrete point. Why? What is it mechanistically that makes that apparently more effective for preventing MI versus stenting the culprit lesion?
Yeah, it's a great question, Greg, and good to see you. I think it's, well, first of all, I think it's going to be, and we'll see what the longer term data show, less of an issue, partly because medical therapy has gotten so much better, or maybe better, but also compliance with medical therapy has gotten better too, in both groups. So the differences in MI, I think, are less than we're typically seen, because both patients benefit, both groups of patients. But I think, again, it gets back to, when we stent, we just fix that one focal tight lesion. But when you bypass, you're bypassing 2/3 of the vessel. And as we know, atherosclerosis is a diffuse process. And, there are lesions that we may not even appreciate angiographically that could progress. There is this concept that these milder lesions are constantly rupturing and healing and rupturing and healing. And occasionally one of them is going to cause a clinical event. And so the bypass, will protect the patient against that event from occurring, because that area of the myocardium is going to get supply from the bypass. So I think that's probably the main reason.
And sorry to belabor this, but that's part of what always confused me, is that it's still only bypassing at one small segment of the coronary. So if the issue is progression of plaque, that could still be in either direction, and there's nothing magical about, it's not that you're actually, and maybe there is something that I'm not understanding, something about that flow that's somehow, positively affecting the remainder of the artery.
Yeah, I guess, I see what you're saying. I guess one way of looking at it, it would be just say focusing on the right coronary, where, really the right coronary is just a conduit, and then the PDA and the PLV really supply the myocardium, and the right coronary is just a tube. And so even though you're just bypassing one point, you're supplying blood to that whole distal bed. And so if you have a mid-right coronary acute MI and you had stented the proximal right, the whole distal bed will be protected by your bypass, but it won't have been protected by your stent. Now, I can see what you mean, like in the LAD, you could compromise septal flow or a diagonal that the bypass isn't really going to address, but it's still the distal bed will be protected by the bypass.
Got it. Okay, got it. That's helpful. Thanks.
Dr. Malidi, you had raised your hand.
Dr. Fearon, thank you so much. And so good to see you again. That was a wonderful talk. I had 2 questions and wanted your perspective on this. FAME2 was just stable CAD. And I know that you had some patients in FAME3 and FAME1, which were ACS. I know somewhat of data for, the use of FFR in ACS. Do you consider it equivalent in both stable as well as ACS? That's one question. And the second is to go off just our discussion with what Dr. Marcus asked. In the FAME2, you really showed that you could kind of detect plaque vulnerability with FFR. In the patients that you had the MI, do you have data that wherever the MI happened were from those same lesions where the FFR was actually done? Did they corroborate, and was your plaque vulnerability in that what you detected? Did the MI happen in those? Do we have that data?
Yeah, nice to see you, Jaya. Yeah, those are great questions. The first one about the reliability of coronary physiology and FFR in particular in ACS is somewhat controversial. We did look at it in FAME1. We looked at the benefit of FFR guided versus angio guided in the ACS group versus a stable group, and the relative risk reduction was similar, suggesting that it is just as beneficial. We haven't done those analyses in FAME3 yet. I think the concern is that, particularly in STEMI, you can't really rely on FFR in the culprit vessel because there's so much microvascular dysfunction, and that is transient, and you can't rely on getting maximal hyperemia in that setting. So we don't recommend FFR in the culprit vessel, probably not in non-STEMI too. However, in the non-culprit vessel, there's a lot of interest, and there's data that suggests you can rely on FFR in the non-culprit vessel. The concern would be that maybe there's global microvascular dysfunction, and therefore in the acute setting, you won't get maximal hyperemia. You'll get a higher FFR than you should. And then if you bring the patient back a month later, now that the microvasculature is recovered, you'll have a lower FFR. But in fact, studies that have done those serial measurements have shown not a really dramatic difference. So I feel it's reliable. I mean, the other concern is that even if it's a negative FFR, maybe, the inflammatory milieu and the plaque, maybe it's not safe, and that it still, is a risky lesion in the non-culprit vessel. But I feel like medical therapy is the treatment for that. And putting in a stent, to seal the plaque is probably not the best way. Now, we'll need more data to show that, but so far I feel reassured that you rely on it. And then the other question was regarding, again,
it was regarding the vulnerable plaque and whether you had the MI.
Oh yeah. So we do have some data from FAME2. Yeah, that the lower the FFR, the higher the event rate. So there was that correlation with MI. So in fact, those lesions that have the lowest FFR do have the greatest chance. And, we published, I didn't show this, but we published a small report in JACC that looked at asymptomatic patients. And, one of the issues with FAME2 was there was a lot of crossover from medical therapy to PCI, and that would theoretically protect the patient. And if you look at in the asymptomatic patients with low FFR, you actually have a higher MI rate. And then if you look at the symptomatic patients, it's not that different, but their crossover rate's much higher. And so we would argue that because they have symptoms, they have like a warning sign that helps protect them from getting the MI. So it's interesting.
Thank you so much for that.
Yeah.
And then one of our fellows, Dr. Walker, has a question.
Hi, Dr. Fearon. Thanks so much for your talk today. I actually have a question on a different subject, kind of about the origins of your research. I'm in the second year class and we're all preparing our research, for third and fourth year, et cetera. And I can only imagine the amount of critical thinking, paperwork, meetings, et cetera, that goes into large trial designs. I'm just curious where you started in your research career and just how you got to the point where you are now.
Yeah, it's a great question, Shannon. And sorry, we can't, spend more time talking about it. I think, early on, of course, you can't just start off doing a huge multi-center trial. You don't have the experience, you don't have the logistics, resources, and so forth. So I focus just on single center, site, just small studies. In fact, the first was animal lab, and then little small human studies, and then you start to build up your experience and build up your credibility or whatever, and you're able, because getting funding is challenging too, and I think you need to build a track record before you can get either NIH funding or get funding from industry. So you definitely have to start small, and then you kind of have to work your way up.
And do you think your animal lab experience impacts the work that you do now?
I do, partly because having that experience now, I can help mentor trainees and junior faculty to do similar studies. I think there's, it's you have much more control over those studies, and it helps you really, gain a lot of experience. So I still draw from those experiences and still do some animal research currently.
Great. So we have one question from Dr. Goldschlager, and then we have two folks who've raised their hands, and then I think that we'll call it time at that point. Dr. Goldschlager's question has to do with the difference in atrial fibrillation rates that you had seen in the CABG and PCI arms, and wondering why you might think that there were higher rates in the CABG arm.
Yeah.
Let me, Bill, thank you, and Leila, thank you. I just wanted to kind of clarify my own question is, if you were surprised, which you may not be because of the difference, the procedural difference, if you were surprised, what are your thoughts about why this happened?
I wasn't surprised, or we weren't, because, and thanks for the question, Nora, because all the previous studies have shown similar things. I think it's, pretty well known that there is a higher incidence with CABG just from the invasive nature, I think, of it. And I would turn to maybe Greg Marcus or someone who knows more about atrial fibrillation than I do, but that it's definitely higher rates after that. And the reason I sort of highlighted that is because, historically, repeat revascularization has been considered an important outcome or endpoint. But really, currently, it's an outpatient procedure in most cases. It's almost like just going to a clinic visit even. And I think the focus on that maybe doesn't need to be as great as some of these other endpoints like atrial fibrillation, which typically leads to the need for anticoagulation and, can lead to other adverse outcomes. So anyway, that was part of the reason for sharing those data. But I don't exactly know why it is, but certainly after CABG, also after open AVR, we definitely see higher rates of atrial fibrillation.
Thank you.
Dr. Thadakara, you had raised your hand?
I have one question. So how many patients in the FAME3 trial receiving CABG had total arterial revascularization?
Yeah, it's a great question. Thank you. So only 25% had total arterial, or actually I should even say had more than one arterial revascularization. So we strongly encouraged in the protocol, multiple arterial revascularization. And but despite that, the surgeons do what surgeons, just like, proceduralists, I shouldn't say surgeons, proceduralists do what proceduralists do. So we would hope that it would be higher. Although it's interesting that, the data haven't really, although intuitively you'd think you should have better outcomes, they still haven't really, shown that. So, you could argue that maybe it didn't really matter in the end.
Okay, thanks.
And then lastly, Dr. O'Brien.
First, I still can't get access. Still a disaster. No lab. Question for you. So we're doing obviously a lot of shock and stuff in the ICU. And I was wondering if you've ever done any FFR studies in low flow states. Because one of the things that we struggle with some of our patients, we have people that have very few options, and like an LAD may be totally CTO'd, and then they've had progression of their circ or RCA, which is feeding huge collaterals. And, we'll be in like a transplant versus intervene window. And we're trying to get a sense of like, what would be is it worth the renal injury of cathing somebody in a complex situation? Have you ever done any physiology studies or aware of any work in that population where that's been of significant value? Because I feel like we chase our tails in those situations all the time.
Yeah, well, first of all, it's good to see you, Connor. Congrats on all you have been accomplishing. Yeah, those are tough patients. And I mean, my bias is that we use our clinical judgment because there's so many different factors that can affect the physiology in those settings. I mean, people have looked at, for example, you know, if you have an intermediate lesion and how does an Impella or ECMO affect your FFR, you know, at various levels. And it's pretty complicated. And so, you know, in general, I don't really recommend. I think it becomes more of a science experiment. And I think you just need to look at the big picture and use your clinical judgment. And I don't think there's a great role in those acutely ill cardiogenic shock type patients for physiology.
Then don't tell my colleagues what you think of my clinical judgment. Sorry.
Awesome. Well, thanks everyone for the questions. And thanks so much again, Dr. Fearon, for taking the time out of your day to spend chatting with us and sharing all the work that you've been doing.
Thank you. Thank you again for the invitation. It was a lot of fun.
Take care, everyone.